lack of mobility, heart failure, with whether it is heart failure with reduced ejection fraction, preserved ejection fraction. They are the ones in whom hypertension control is of paramount importance. Then there is one thing which everybody should know, that is a risk scoring system called SCORE, because it is helping you decide which patient needs treatment or not. So this is available online everywhere. It's available as a form of app also, you can download it. It helps you in placing the patient at high risk, moderate risk and low risk, thereby helping you with the treatment. So first thing is, if any patient comes to you, you have to confirm their diagnosis. So you will screen the patient for hypertension, then you will label it as a non-elevated BP, as an elevated BP or hypertension, and then you will start and classify and start the treatment. Suppose the BP is normal, then this warrants treatment. You confirm the BP promptly, and you have to start the treatment as early as possible. Now start the treatment as early as possible. Now why I am insisting you have to start the treatment, because hypertension in any form will always start silent end organ damage. The two organs which we are very much worried about, which basically come at a delayed time, is eye and kidney. Specifically, we are talking about microvascular remodeling and retinopathy in the eye, and in the kidney, we are talking about early nephropathy, which starts as microalbuminuria and then goes into arterial hypertension and maybe proteinuria, and finally they come with CKD. So these are the two silent killers because of hypertension. In addition, from the cardiac point of view, definitely there is a left ventricular hypertrophy, and the risk of coronary artery disease and myocardial infarction is very high. Brain, as sir already said, dementia, which is very much ignored, as well as CVA. And also at the level of microcirculation, peripheral arterial disease also is one of the things which you need to be worried about. Whenever any patient comes, and once you have diagnosed the patient as hypertension, we always ask you to get a routine battery of checks to be done, because usually hypertension in isolation is very rare nowadays. Usually diabetes and hypertension are twin brothers. They will be there together. So always any hypertensive, get a fasting blood glucose done, get a cholesterol done for dyslipidemia, check for electrolytes, get a creatinine done baseline, get a 12-lead ECG done, and echocardiography specifically to see if already the patient has landed up with LVH or in the stage of hypertension mediated end organ damage. And also get one very simple test for peripheral arterial diseases, ankle brachial index, so that you can do in your clinic itself. So that also needs to be done. Now coming to treatment, first thing is get screening done properly. So any patient less than 40 years, at least once in 3 years, let them check the BP. But every year for a patient more than 40 years. Then you confirm the diagnosis, then categorize the patient, whether it is a non-elevated BP, elevated or hypertension, use the score which I have elucidated, and then you can start the treatment or leave on lifestyle modification, it depends. So whenever a person is hypertensive, you have to always emphasize on non-drug mediated therapy also, which means patient-centered care or lifestyle care. So the approach to treatment of hypertension means lifestyle, medication, then multidisciplinary team if the patient has landed up in complication, family and self-care. So in lifestyle, you have to keep on emphasizing physical activity. Physical activity, weight management, diet, and reduction of table salt in diet. Because here we are very fond of spicy food, so that needs to be emphasized. So this is one simple slide which I have put so that you know what to tell your patients. So first thing is restrict salt to less than 5 grams per day, but Indian guideline says less than 2 grams per day. Alcohol consumption in any form should be restricted. If in European studies they say it is less than 14 minutes, but Indian studies have shown alcohol is not good, you should just quit. Vegetables, fresh fruits, fish, nuts are good. Red meat is a strict no-no. Ask them to decrease their body weight. If the weight is more, BMI is more than 30 and waist circumference is more, they have to reduce it. And aerobic exercises, especially more than 30 minutes, dynamic exercises at least 5 days a week is mandatory. Smoking has to be completely stopped. Now, among the exercise, the most common question will be what to do. So you have to advise that in a week, 150 minutes of moderate intensity exercise has to be done. You have to basically increase your non-exercise activities also, like take the stairs wherever possible, go by walk, don't use vehicle. And isometric resistance training exercise, basically low intensity exercises like a plank or wall sit up at least 2 days a week. That is very important. Okay. So totally at least 150 minutes in a week should be the target for everybody. And in that, make sure that 2 days they have to do this, what you can say, isometric exercises. Then coming to the treatment, which patient to give what? This biggest confusion because there are so many drugs in the market. What you have to understand is that the latest guideline emphasizes that you have to always start with at least double therapy. Single therapy has been relegated to only certain group of patients, that is age more than 85, the patient who is very frail, and those who are in the elevated BP category but not in the hypertension. Once a patient is hypertension, he has to be on 2 drugs. So preferably any combination, any drug is good enough. There is nothing like you have to give only ACE inhibitor or ARB or calcium channel blocker, but make sure that we are also seeing what the underlying end organ damage is there or not, because that will decide what to do. So once you have started a patient on a dual therapy, you ask them to keep a close track on BP for about 1 to 3 months. If it is controlled, then ask them to come on an yearly follow-up with all the investigations. If it is not controlled, you start with a triple drug therapy. Again, you measure for about 1 to 3 months. If it is controlled, ask them to come for yearly follow-up. If it is not controlled, then you have to basically go for incremental increase in dose. And if the BP is controlled, then let them come for follow-up. In this entire thing, what you have to remember is one drug which is very important for everybody is beta blocker. If the patient is having any cardiovascular disease, by default he should be on beta blocker. This is one slide which I thought will be useful for you guys, because which drug should not be given in which set is more important. Like ACE inhibitor should not be given in pregnancy, ARB should not be given in pregnancy, beta blocker should not be given in asthmatic. Okay. Similarly, thiazide should not be given in patients with hyponatremia. MRA should not be given in patients with hyperkalemia. These are basics, but for you it has importance. And which drug to use where? For example, diabetics, always better to use ACE inhibitor and ARB because it helps kidney protection. Beta blocker in cardiac patients, no doubt about it. Similarly, if you see kidney patients, always make sure that they are on a loop diuretic. Okay. And there are certain drugs which may influence your BP reading. So make sure whether the patient is taking these medicines like NSAIDs, common medicines like glucocorticoids, NSAIDs. Similarly, patients who are on antidepressants, and also on what you can say patients who are taking some herbal medicine, alcohol. These can influence your BP reading. So you should keep a close watch on that. Then one drug I wanted to just touch upon two things. One is hypertension in pregnancy. You should know how to manage hypertension in pregnancy, because any of your relatives may put you a question and then you should not keep scratching your head. So if a lady is pregnant but less than 20 weeks and she was diagnosed as hypertension, likelihood of her being having a pre-existing hypertension is more. If a lady is having hypertension after 20 weeks, then you can label it as a gestational hypertension. Preeclampsia, it is an emergency wherein there is a gestational hypertension and end organ damage with proteinuria that needs to be treated. So what you remember is no ACE inhibitor, no ARB, no diuretic. The drug of choice in the pregnant ladies are fairly limited: methyl dopa, labetalol, and calcium channel blocker. These are the 3 drugs which you can use safely in pregnant ladies. Okay. Then I have just put alpha methyl dopa is available in injectable and tablet form. How to give the dosage I have just put for you people. And labetalol also, it is available in injectable form and oral form. And how to give that also I have mentioned the regimen, just so that anybody asks you, you should not be scratching your head. Then coming to resistant hypertension. So it is a very, what you can say, misused term, because most of the time hypertension is not resistant. It is the patient who is resistant to taking medicines and causing resistant hypertension. So if the patient is having a BP of more than 140/90 despite 3 or more medicines at maximum dose, and this includes a diuretic, and you are sure that he is taking the medicine, then the patient is having resistant hypertension. Such patient, first thing is make sure whether he has taken medicines and is he following lifestyle modification or not. Second thing, if it is true treatment resistant, then you have to add one drug, that is a mineralocorticoid antagonist, that is spironolactone, and also a beta blocker. Usually these patients will respond well to this combination. And then if still patient is not responding, then there are other centrally acting drugs like alpha blockers and also potassium sparing diuretics other than mineralocorticoid, which can be used. Still, if the patient is not responding, then there is a device-based therapy called renal denervation, which has come. But I think that most of the time it is pseudo-resistant hypertension which we are encountering. The cause is basically white coat phenomenon, not taking treatment properly. There may be a brachial artery disease, a peripheral arterial disease, wherein you are recording spuriously the high pressures. Therefore, you have to always check at more than 2 sites whenever a patient comes to you. Then the last part of my talk is about secondary hypertension. See, you cannot label any person just like that hypertension. You have to always see whether you are missing something or not. So if a young patient comes to you as an hypertension emergency, or a person who was having a good control but suddenly worsened very badly, landed up in high heart failure, a person who is having other endocrine sort of features. Similarly, females, they may come with arthralgia, history of myalgias. These are the patients, and obese people. These are the patients where secondary hypertension is a reality. So I have tried to cover the most common causes of secondary hypertension. First is a renovascular hypertension, wherein there is a stenosis in the renal artery, wherein the patients will persistently come to you with a high BP. So at least get a renal artery Doppler done for any person who is having a persistently high BP despite your adequate treatment. Okay. And last is a obese person who is coming to you with obstructive sleep apnea. That sleep apnea itself is a cause of hypertension, and you can easily treat it with weight loss, CPAP along with your regimen. So these are the two things I wanted to just add. I'll conclude by saying that hypertension is one of the most easily missed and misdiagnosed condition, and you should be adequately equipped to treat it. Right. Thank you.
Thank you, Bhatia. Exhaustive speak. You spoke very well. Only thing is, I request all the speakers to give a 10 salient points to learn from this CMA program. So whenever you teach, at least the audience should leave with 10 important points. So please focus on that. And because we have a 6 speakers, please stick to only 10 to not to exceed more than 15 minutes. So please pay attention, and after going home, I think you are all going to hostel, review the hypertension topic. That's the best way to learn. Hypertension, many times if you go to any house, like a father, mother, or grandfather, someone will have a hypertension, diabetes, or cholesterol. You must know. They will ask you, don't cut a sorry figure. So you must know these 3 important things. And the next speaker, Dr. Parth Saradi, he's going to talk on management of lipids. Please bear a minute. Sorry. Slide. Okay, sir. అంటే స్లైడ్ షోకి వెళ్ళి గో టు స్లైడ్ షో నాట్ కమింగ్ స్టక్ అయిందా మేబీ ఒకసారి స్టార్ట్ అదర్వైజ్ ఇంకో next speaker, Dr. Rohan Reddy, topic is dyspepsia, is one of the main gastroenterologists of Kim Sunshine. So very young and dynamic. So I told him to discuss about the dyspepsia management because this is also very common topic. So one must know the peptic ulcer, how to treat all those things. You can go ahead with that presentation.
Comes. Good evening, everyone. At the outset, I want to thank Sridhar Kasturi sir and Hybiztv for inviting us here on this day to talk about to give this information to all the students. So I'm going to keep my presentation very simple and very straightforward so that you learn something out of this. So my topic is going to be I'm going to talk about how to approach a patient with dyspepsia. So what are the things that you're supposed to know about dyspepsia? What are the common investigations and what are the different conditions that you'll have to suspect, and what are the investigations that you'll have to do, and what are the treatment options. So I'm going to talk in lines of introduction to dyspepsia, the proper definition of dyspepsia, the most common causative pathophysiological conditions that lead to dyspepsia. How do you evaluate a patient who comes down with those symptoms? How do you evaluate systematically these kind of patients, and how do you initiate management in these patients? So dyspepsia, as you all know, is a very common, is a very layman's term of describing a set of conditions. So it has a very extensive differential diagnosis and very heterogeneous pathophysiology. It occurs in approximately 25% of the population. So each year, so that means it's a very common condition that each one of us at some point of time do experience this. Although dyspepsia does not affect survival, it is responsible for significant healthcare costs because you lose a lot of productive days in your life. You lose a lot of uh, uh, office time. You lose a lot of college going time because you are sick and then you're morbid because of dyspepsia. So how do you define dyspepsia? So it describes a different wide and common clinical entity which presents in one of the three ways. So your patient comes down to the clinic either complaining about mild epigastric pain or discomfort. So this condition is called as epigastric pain syndrome. So this is very non-specific. You get a lot of patients on a day-to-day basis saying that they have some kind of non-specific pain. There's some kind of abdominal bloating and some kind of discomfort that they experience. And the second most common symptom that patients present is with postprandial fullness. That means once they have food, let it be after breakfast, lunch, or dinner, so they'll have a kind of fullness in their stomach. So this can also be one of the terms that patients on a common usage use for dyspepsia. And then early satiety. So patients do come to the clinic also saying that they're full with a very small quantity of meal, or they say they have the condition of indigestion. So all of these terms collectively refer to a diagnosis called as dyspepsia. So, what are the causative factors of dyspepsia? It has a multiple pathogenic factors and a different set of symptomatology and different diagnosis, which can lead to a similar pattern of presentation as that is experienced with dyspepsia. So, your patient once he comes down to the clinic with these set of symptoms. So, what are the differential diagnoses that you should be thinking about? So the differential diagnosis first thing is whether you need to identify whether this patient has a structural or an organic disease associated with these symptoms. So the differential diagnosis when it comes to any patient with an organic disease refers to one of these conditions. It can either be a peptic ulcer disease, it can be something as simple as a gastroesophageal reflux disease. Sometimes when these patients have set of alarm symptoms, I'll be talking about alarm symptoms later on, but it can also be because of any gastric malignancies or any other gastrointestinal malignancies also. Sometimes it can be related to drugs. So very commonly we have a lot of patients who are self-treating themselves with painkillers or NSAIDs. So this can cause NSAID induced gastritis or NSAID induced ulcer disease, which can have a similar presentation to dyspepsia. And other rare conditions such as inflammatory bowel disease, that is Crohn's disease, and chronic pancreatitis can also have a similar set of presentation. And the second differential diagnosis is those patients who do not have a organic disease. So these patients fit into the criteria of something called as functional dyspepsia. So I'll be talking about these conditions in detail from now on. So when it comes to peptic ulcer disease, so we commonly refer to this term as patients who have ulcers. These ulcers can be present most commonly in the duodenum or in the stomach. So these patients come to the clinic with presentations of discomfort or abdominal pain. And most prominent symptom in these patients is because of peptic ulcers. So the classical set of symptoms differs when it comes to duodenal ulcer. These patients have pain a few hours after they take a meal, because food usually acts as a buffer. So as you all know, acid is secreted in the stomach. So when there is ulcer in the duodenum, there is no more acid to act on that ulcer to cause pain. So that is why these patients immediately after eating a meal, they do not have any symptoms, and in fact their pain is decreased. So this is a classical symptom of someone with duodenal ulcer. And when it comes to gastric ulcer, because it is there in the stomach, any meal, because meal increases the secretion of gastric acid. So because there is increased secretion of gastric acid immediately after a meal, there is increase in the pain after a meal in cases of gastric ulcer as compared to duodenal ulcer. So peptic ulcers can also be, that is both gastric and duodenal ulcers can be also associated with postprandial belching, that patients complain of regurgitation, patient sometimes complain of hiccups, patient complains of epigastric fullness, that is this fullness in the upper quadrant of the stomach. And then fatty food intolerance can also be one of the rarer symptoms, and nausea and occasional vomiting can also be seen with ulcers. Next is patients with set of dyspepsia symptoms can also be because of condition called as gastroesophageal reflux disease. So this is one of the most common symptoms that lot of patients or lot of any, it can be generally present in the general population also. So the most common set of symptoms are retrosternal burning pain and regurgitation. So patients usually complain of severe pain in the middle of the chest, something what we call as heartburn. So a lot of patients usually do confuse this as something related to a myocardial infarction or a heart attack, and then usually end up going to a cardiologist also sometimes. So GRD should be suspected in all of these patients when the symptoms accompany dyspepsia, that is, patients complaining of that postprandial fullness or that epigastric discomfort and satiety after a meal, along with symptoms of regurgitation as well as heartburn. So gastroesophageal malignancy. So in case of gastric malignancies, that is stomach cancers, patient can also have these set of symptoms, that is epigastric pain or discomfort and postprandial fullness. But what you need to identify in these set of patients is whether these patients have any alarm symptoms or not. So when we are talking about alarm symptoms, you should look at whether the patient is losing any weight, whether the patient is does not have any normal appetite, he has an early satiety, or if the patient is aged above the age of 55. So these are common set of symptoms that you need to identify when it comes to malignancies, any malignancies for that matter. Then biliary pain. Sometimes vague presentations can also happen with biliary collicate kind of pain. So normally biliary pattern of pain is more pronounced on the right hypochondrial region. But sometimes an exception to this is patients can also have an epigastric discomfort. So normal rule in case of biliary pain is patients have a right hypochondrial pain, and then there is exception can also be sometimes rarely present in these patients. So when you rule out all the other conditions where patient you think the patient does not have any gastric ulcer or duodenal ulcer, patient does not have any symptoms related to gastroesophageal reflux disease, or there is no malignancies for that matter, so biliary pain can also has to be taken into consideration in these set of patients. So functional dyspepsia. So functional dyspepsia or otherwise non-ulcer dyspepsia is to be seen in those patients, or you need to identify these set of patients when patients does not have any structural disease. Say when all the investigations, all the traditional investigations that we do for pain are completely normal and the patient still continues to have pain, this pain can be referred to as functional dyspepsia. So pathophysiologically, what happens is these patients have a visceral hypersensitivity, where their nerves are too sensitive that even a normal meal can induce a pain. There is nothing wrong in the stomach, there is no ulcers, there is no GERD, but the patient still complains of pain. So this category of patients are diagnosed as to having functional dyspepsia or non-ulcer dyspepsia. So how do you evaluate these patients? So the first and the foremost important thing when you evaluate any patient is you take a proper history. So history, usually you end up diagnosing a lot of patients just by history itself, and investigations are just only an add-on to your history. So as medical students, what you need to understand is proper history taking is very, very important, and don't rely just on investigations and then just once we go into internship, what happens is, because you just tend to write a lot of investigations, but what people are forgetting nowadays is that you need to take a proper history in a lot of patients, and then history gives you the clue for at least 70% of the diagnosis. So a dominant history of heartburn, regurgitation, or cough in patients with these set of symptoms can be suggestive of gastroesophageal reflux disease. In NSAIDs, if you ask a patient whether they are having any drug history or whether they are taking any over-the-counter pain medications, this can be because of NSAID-induced peptic ulcer disease. Significant loss of weight, anorexia, vomiting, dysphagia. So these are all alarm symptoms. So in these patients, you need to suspect in terms of gastrointestinal malignancy also, and the presence of severe episodic epigastric or right upper quadrant abdominal pain lasting more than an hour and then the pain suddenly gets better can be a classical symptom of biliary pattern of pain. So next is physical examination. So physical examination in a lot of these patients is pretty much normal except for epigastric tenderness. So epigastric tenderness sometimes can be because of duodenal ulcer, can be because of peptic ulcer, can sometimes be because of biliary cholecystitis or a choledocholithiasis. So other findings on physical examination may include a palpable abdominal mass in cases of any malignancies, lymphadenopathies, that in case of CS stomach, you have a left supraclavicular lymphadenopathy, or a periumbilical lymphadenopathy in case of gastric cancer also. Jaundice can be an add-on symptom in patients with a biliary pattern of pain. Pallor, that is significant anemia, can be seen in some patients with gastric ulcers or duodenal ulcers also. So what are the other alarm indicators except for whatever we have spoken about is advanced age. So anyone more than the age of 55 and you have these symptoms for a prolonged period of time, then it is important. So why is alarm symptoms important is you need to be more thorough with the investigations in these patients and not treat them just with basic medications in the first instance itself. So unintended weight loss, progressive dysphagia or odynophagia, unexplained anemias, hematemesis, lymphadenopathy, previous history of any gastric surgeries, persistent vomitings, and any palpable abdominal mass or jaundice, can all of these be alarm symptoms. So what are the investigations that we do in these patients? So common blood count or a common blood picture. In rare cases, you do an antibody for H. pylori investigation because this is responsible for a lot of patients with gastric and duodenal ulcers also. A stool for occult blood in areas where there is no easy access to endoscopy. Liver enzymes, that is a basic liver function test, and the gold standard in a lot of these patients is doing an upper GI endoscopy. So whenever a patient walks down to your clinic with symptoms, that is of epigastric discomfort, that is with any postprandial fullness or early satiety, so what do? First thing is first, you take a proper history, and you think that these patients have some kinds of an alarm symptoms that we were talking about earlier. So make sure he gets an upper GI endoscopy in the first instance itself, because this is the gold standard, easily done investigation, just takes 2 minutes, and we rule out most of these conditions by doing an endoscopy. So what if the patient is less than 55 years and there's no alarm symptoms? So consider H. pylori infection. So India usually comes under the endemic region for H. pylori. That means a lot of us are infected with H. pylori. So give all of these patients a trial with proton pump inhibitors. If the proton pump inhibitors therapy is failed and the patient continues to have symptoms, then test and treat for H. pylori infection. That is, test with basic blood investigations or a stool investigation for H. pylori and treat them accordingly. And if the patient still continues to have symptoms, then do a endoscopy. If the prevalence of H. pylori is more than 10%, that means as to what categorizes in Indian population, you test and treat for H. pylori in the first instance itself. And if the patient still does not respond to this therapy, go ahead and do an endoscopy in these patients. So endoscopy usually gives a positive diagnosis in a lot of patients with organic disease, that is GERD, that is with gastric or duodenal ulcers or with any GI malignancies. And if the patient still, if the patient there is no nothing wrong in the endoscopy, then we should actively consider the category of patients having functional dyspepsia also. So treatment again includes for H. pylori. We give a H. pylori regimen. That is the most commonly used H. pylori regimen is the triple therapy with 2 antibiotics and a proton pump inhibitor. And if the triple therapy fails in some patients, then you can also use the quadruple therapy where we add bismuth subsalicate to the 2 antibiotics and PPI additionally. So that is pretty much my talk. So if you have any questions, please feel free to ask.
We'll keep question and answer session to the end. The next speaker, Dr. Shirish Kumar, Asthma Management Beyond. Shirish, you can come.
Hello everyone, I'm Dr. Sirish, consultant pulmonologist at Kim Sunshine Hospitals, Begumpet. I would like to thank Dr. Sridhar Kasturi sir and Hybiztv for giving this opportunity. Asthma is a very common disease. I think most of you might have seen asthma patients getting treated in your hospitals, and maybe in your friends and family also, you might have come across the patients who are suffering from asthma. And through this topic, I would like to educate you all about the common mistakes which asthma patients do in the treatment part. And also, I would like to educate you all there are certain treatment options which are available beyond inhalers also. So, related death. That might be the reason they take it very lightly. But shockingly, there is a data which shows that India now contributes to an alarming 42% of all global asthma deaths, although it accounts only for 12% of global asthma cases. So asthma-related deaths is alarming. So each asthma patient has to be educated properly for their good asthma control. So let us go into the topic and let us see why this asthma is uncontrolled in certain set of patients. Most of the times, the medication has to be adjusted. When this medication will be adjusted, then the asthma symptoms will come under control, and these patients are labeled as uncontrolled asthmatics. And if at all a patient has comorbids like GERD or acute rhinosinusitis, and if they are not corrected, then the patient will have recurrent asthma symptoms, and these patients can be labeled as difficult to treat asthma. And once these comorbids are corrected, like sinusitis is corrected with proper medical management or a surgical management, dyspepsia is managed with proper management, then the asthma symptoms also come down, and thus the treatment will be completed. This set of patients will be labeled as difficult to treat asthma. Then last comes severe asthma. Here, this is the topic of interest, that is severe asthma. You will give all the medications which are there in your hand, like high dose inhalers. You will correct comorbids, and still the asthma is not under control. Then we should think about something called biologicals. So this is where our biologicals come in place. That is asthma treatment beyond inhalers, what we talk about. So how common is severe asthma? About 3.7% of asthmatics will have severe asthma. I was saying that there is a questionnaire which should be asked to all the asthma patients, so that you will get to know whether the patient is having controlled asthma or not. This is called asthma control test, and this is a set of 5 questions. Each question carries 5 points. For example, the first question you can see, in the past 4 weeks, how much of time did your asthma keep you from getting as much done at work, school, at home? That is, the asthma is disturbing him at workplace. If it is not disturbing, it is a higher score, that is score 5. If it is disturbing a lot, then it is lowest score, score 1. So accordingly, we have set a questionnaire, and out of 25, if a person scores less than 19, then that person's asthma is not under control. So I think most of you have seen Dr. House web series, where you can see one of the patients when asked by Dr. House that how you are using your inhaler, she demonstrate in this way. So we have to educate our patients. Although we start on medications, we have to demonstrate each and every time they come to our OPD visit how they are taking the inhalers, whether they are following all the proper steps or not. So before confirming severe asthma, first we should confirm the diagnosis, because all wheezes are not asthma. So whenever wheeze is just one of the presentations of asthma, and we should be very sure that the patient is suffering from asthma. Then we should go looking for other factors like improper inhaler technique, comorbidities, and then correct everything and check and give the treatment for at least 4 to 6 months. Then only you can label them as severe asthmatics. So this flowchart sums up the previous slides. Whenever a patient is having uncontrolled asthma symptoms, you should confirm the diagnosis again, identify and treat the contributory factors like triggers. If a patient is having pets at home, you should ask them to avoid them. And some people will have occupational asthma. For example, school teachers who are getting exposed to chalk piece dust daily, these are the triggers for them. So you should ask them to change to other modes like a marker with a whiteboard. So there are certain, you should dig deep into the history, and you should see what is happening to him, why his asthma or her asthma symptoms are not getting under control. We have a plethora of medications. We have very wide range of gadgets in inhalers, and each gadget is different, and you should explain them very properly. Each step is important. So we are discussing about severe asthma, but before going to severe asthma, we should always check whether this patient is on maximum medical therapy or not. For example, if he is on low dose inhaled corticosteroids, he might have he might require a higher dose inhaled corticosteroid. You should step up the treatment and you should check. And still, if he's not getting better, then he goes to step 5 of asthma management. In this step 5, we will do certain tests to check how is this patient. As I already told you, each patient is different, and we should phenotype them. We should subgroup the asthma patients and accordingly treat them in this step 5, in this uncontrolled or severe asthma patients. One size does not fit all, so we should categorize each patient and give a tailor-made therapy for them. For example, I'm just sharing few phenotypes. Some patients may be grouped under early onset allergic asthma phenotype, where they have atopic dermatitis and allergic rhinitis. Some patients can be grouped under late onset minimally atopic eosinophilic. That is, the onset of asthma is during their late 50s or 60s, where they have severe airway obstruction, nasal polyps. And also patients can also have late onset non-eosinophilic asthma, that is asthma in the adults, again in the late 50s. So it all depends on whether it is childhood onset asthma or late onset asthma, or it is eosinophilic or it is non-eosinophilic. So accordingly, we'll phenotype them, we'll group them, and we'll give appropriate therapy. So let us see what can we give in these severe asthma patients. This is just pathophysiology, just to show that we will phenotype under Th2 high and Th2 low phenotypes. I don't want to go in deep, at least for this slide. Whenever a patient comes to us to our precise asthma clinic, we have an asthma worksheet. The questionnaire which I have shown you will ask the patient to fill it up, and we'll check whether he's having severe asthma or not. We'll do a serum Ig level, absolute eosinophil count, and PFT, and if required, a chest X-ray or CT chest, and we do phenotype them. And accordingly, we'll advise the plan for them. So according to the phenotype, we'll advise them biologicals. Biologicals are nothing but compounds derived from living organisms or their products. I think you have heard about omalizumab, which is anti-IgE antibody, and we have mepolizumab, which is anti-IL-5 antibody as biologicals for severe asthma. This is a basic pathophysiology of asthma, where IgE and eosinophils play a main role in inflammation, which leads to bronchial hyperresponsiveness and airway obstruction. So if we block IgE and eosinophils, we can block this inflammation, and thus the asthma symptoms will be under control. So omalizumab, anti-IgE antibody, it decreases expression of high affinity receptors on mast cells, and thereby there will be no degranulation of the mast cells. Thus, allergic inflammation can be controlled. Omalizumab is backed up by good studies. This is one of the study where it showed that there is a 44% improvement in fractional expiratory volume. And there are various other studies which showed that omalizumab is good enough. And anti-IL-5, I was talking about mepolizumab, it acts on eosinophils. As you all know, eosinophils are the major allergy cells which leads to inflammation in asthma patients. When you block these eosinophils, then you can inhibit bronchospasm and asthma symptoms in these patients. So again, mepolizumab is also backed up by good clinical data. So that's about the theoretical part. Let us conclude the talk by seeing two cases. First case, there was a lady, 67-year female, and she was a retired nurse, no addictions. Her BMI was 26. She was hypertensive and diabetic, and she had a history of tuberculosis in her lungs 30 years ago. She was diagnosed as asthma about 5 years ago before presenting to us, and she is on regular medication. Being a nurse, she used to follow all the medications whichever we used to prescribe her, and despite of best medications, she used to get um, recurrent symptoms, and she used to get admitted for frequent exacerbations, almost 2 to 3 exacerbations every year. And whenever she is getting admitted, we used to give oral corticosteroids or IV steroids for her asthma control. Then we enrolled her into a severe asthma clinic. We checked the inhaler technique, it was good, the compliance was good. She was having GERD, that was also managed well. There was no emotional stress, and other diseases are also ruled out. Then we have phenotyped her, and on phenotyping, we came to know that she is Th2 high type of asthma, late onset and atopic. So we have started on a biological called omalizumab, that is injection, subcutaneous injection, 300 mg for every 15 days. And after starting this, at least 3 months later, there were no exacerbations and her asthma was well in control. And it's been almost 3 years now. She has never been admitted for asthma exacerbation again. And second case, 65-year-old male. Again, he also had asthma history that was not at all getting control with routine medications. We have phenotyped him, and we got to know that his eosinophils are high. And we have started on mepolizumab, and now he's doing well without any exacerbations. So, to conclude, asthma is both easy and also hard to treat in certain set of patients. It is easy because we can just adjust medications, we can treat comorbids, we can adjust the inhaler technique, and we can give certain combination of medications where majority, 90% will get a proper result. And you should check inhaler technique at each visit. Whenever they visit to you, you should check the inhaler technique. And certain subset like 3 to 10% may have severe asthma, for which expert opinion is needed. And there is a promising role of biologicals in these subset of patients. Thank you.
Thank you, Shirish, for a wonderful presentation. Now the next this is also a very important topic, approach to fever of unknown origin. I request Pavan again, I'm emphasizing again and again, because audience see that the basics of a fever evaluation, like when you go to viral, everything, like a common test, and a common, only keeping the audience interest and everything.
Good evening, everyone. I am Dr. Pavan. I am a physician. So I thank Dr. Sridhar Kasturi sir and Hybiztv for giving me this opportunity. Today I am going to brief regarding the approach to fever of unknown origin. So it is an important topic, and I would like to tell you that every fever should not be seen as fever of unknown origin. First, my overview of my talk is first is definition, then etiology and epidemiology, a differential diagnosis approach to a patient, algorithm in approach to fever of unknown origin, then first stage diagnostic test, that is FDG and PET CT. How is it helpful? And later stage diagnostic tests, and what are the treatment options and the prognosis. So fever of unknown origin, it is also known as pyrexia of unknown origin. So any febrile illness without initial or obvious etiology, it is considered as a fever of unknown origin. But my suggestion is every fever without symptoms like cough or burning micturition, every fever should not be seen as fever of unknown origin. So we'll see the definition. So fever more than 38.3 degrees centigrade or more than 101 Fahrenheit on 2 occasions, or 2 weeks of duration, 3 weeks of duration. Next, no known immunocompromised state. So diagnosis remains uncertain. So after thorough history, physical examination, and intense obligatory investigations. So we'll see the what are the investigations we have to conduct. That is CBP, ESR, and electrolytes, creatinine, protein electrophoresis. So LFT and LDH, creatinine kinase, ANA. So urine analysis, blood cultures, 3 sets of blood cultures, 10 ml each, and urine culture, chest X-ray, ultrasound abdomen, and tuberculin test. These tests should be conducted, but it depends on patient to patient. So next recent update is, and it is also known as inflammatory of unknown origin. In this, there will be no fever, but there are elevated inflammatory markers, that is C-reactive protein and erythrocytic sedimentation rate. So for elevation for at least 3 weeks in an immunocompetent patient with normal body temperature, for which a final explanation is lacking in spite of history taking physical examination and after the conducting the obligatory tests. So we'll see the etiology and epidemiology. So most common cause in non-Western countries are the infections that constitutes 40%. In that, 50% constitutes tuberculosis, and most common cause in Western countries are non-infectious inflammatory diseases. So we'll see the causes first. So 40% constitutes infections. Next 20% constitutes neoplasms. Next 20% non-infectious inflammatory diseases. Next miscellaneous 10%, and undiagnosed cause, it's still alarming to see. So 10% of the fevers are undiagnosed or undifferentiated. So we'll see the infections first. So infections constitutes 40%, as I said. In those 40% bacterial infections, those non-specific bacterial infections are seen apart from the organism. So these are system specific. Those are abdominal abscesses, adnexitis, appendicitis, cholangitis, endocarditis. So infected joint processes, liver abscess, and urinary tract infections. So bacterial infections, these are organ specific. Those are actinomycosis, atypical mycobacterium, brucellosis, leptospirosis, melioidosis. So pneumonia, chlamydia pneumonia infection. So next are fungal infections, aspergillosis, blastomycosis, coccidomycosis, candidiasis. So cryptococcosis and pneumocystis carinii infection. And others are parasitic infection. Those are amoebiasis, babesiosis, malaria, schistosomiasis, toxoplasmosis. So next are viral. Those are cytomegalovirus, dengue, EBV, hepatitis A, B, C, D, E, and HSV. HIV, though HIV constitutes more number of infections in undiagnosed fever. So next category, so non-infectious inflammatory disease constitutes 20% of the infections. So out of these, rheumatoid or autoimmune diseases constitutes, those are ankylosing spondylitis, antiphospholipid antibody syndrome, autoimmune hepatitis, and rheumatoid arthritis, Sjogren's. So next are vasculitis, that is Kawasaki polyarthritis nodosa, and Takayasu arthritis. Next are granulomatous diseases that, like sarcoidosis. So next, autoinflammatory syndrome, adult onset Still's disease, and familial Mediterranean fever, and Crohn's disease. So next, neoplasms constitutes 10%, which majorly are hematological malignancies like lymphoma. Out of them, malignant lymphoma fever predominantly it is seen. Next, Hodgkin's lymphoma, leukemia, multiple myeloma, myelodysplastic syndrome, non-Hodgkin's lymphoma. So other are solid tumors, breast, colon, hepatocellular carcinoma, renal cell carcinoma, and lung cancer. So next are benign tumors, angiomyolipoma, hemangioma. Next, so thermoregulatory receptors, so which in which central causes are CVA. Next, peripheral causes like hyperthyroidism and hypothyroidism. So in fever of unknown origin, the major differential diagnoses which are seen are, so atypical, it should be seen like atypical presentation of common disease. Like we should not think of the rare disease. So first you should think of the commonly seen diseases with atypical presentation. So most common cancerous causes of fever of unknown origin are malignant lymphoma. Next, we should not forget the drug-induced fever. So like allopurinol, carbamazepine, lamotrigine, and phenytoin, furosemide, quinidine. So these are also considered in fever of unknown origin, because always I say thorough history, physical examination is important than the relevant investigations. So next is exercise-induced hypothermia, increased body temperature associated with moderate to severe hyperthermia. So next is factitious fever, in which patient injects contaminated water. And next we see is fraudulent fever, in which patient manipulates the thermometer and comes to you. So this is an important algorithm, so in which you have to follow this in case of differentiated or fever of unknown origin. If you see fever more than 38.3 degrees Celsius or 101 degree Fahrenheit on and 3 weeks of duration, illness for 3 weeks of duration, and no known immunocompromised state. First is, as I said, history and physical examination is important. And next thing is, you should stop the antibiotic and glucocorticoids. So because, if you send cultures, the yield will be low. Glucocorticoids also that that mask the infection. So always you should first and foremost thing, you should stop the antibiotics and glucocorticoid steroids. So next thing, again you have to send these the obligatory investigations. Then you should exclude the first is factitious fever. So whether he is manipulating the thermometer and on. And next, how to exclude the drug-induced fever. If the fever lasts, if you stop the drug and if the fever lasts more than 72 hours, then it is not a drug-induced fever. So always you should exclude one by one. So you should look for the potential diagnostic clues which are present, and we should, if you find potential diagnostic clues, so you have to go according to this chart. You can guide, you can do the biopsies, and if you have diagnosis, you, that's well and good. Otherwise, if there is no diagnosis, again you have to search for the potential diagnostic clues. Sometimes these are misleading also. So cryoglobulin in cryoglobulinemia, and also fundoscopy in retinal arteritis or retinal vasculitis. And next thing is, you should consider FDG PET CT for PET CT for the secondary stage diagnostics. So if it is not available, you have to go for conventional scintigraphy. So by confirmation or of abnormality, you have to do the biopsy and culture. If you get the diagnosis, that is well and good. And if you don't get the diagnosis, again you have to perform the scintigraphy. If it is normal, again we have to repeat the history and physical examination. So perform potential diagnostic clues driven invasive testing. So if you get the diagnosis, it's okay. Next, if you don't get the diagnosis, again you have to look for the chest and abdominal CT. So temporal artery biopsy, if it is more than 55, ESR is high, if the ferritin is high, then if it is an elderly person, you have to consider the biopsy also. So if you have the diagnosis, that is okay. And if you don't get the diagnosis, again, if the patient is in stable condition, again you have to look for the potential diagnostic clues. Like you can consider the NSAIDs in case of elderly. Sometimes we see the with the NSAID treatment, like autoimmune or non-inflammatory infectious diseases also. So definitely we have to consider NSAIDs. And also, if the patient is deteriorating and further diagnostic tests are required, you consider therapeutic trial of antibiotics and also corticosteroids. So first stage diagnostics, look for the potential clues like localizing signs like symptoms and abnormality potentially pointing towards the diagnosis. Like if you see a patient with cough, you have to look for the respiratory system. And for the history is always important. You have to look for the fever pattern, whether it is continuous or recurrent, the duration of the fever, duration of the illness, and the medical history is also important, whether he is on any drugs or recent drug use, and family history, sexual history, so then travel, and also animal contacts. So then for in the physical examination, this is very important. So you should look for eyes, lymph nodes, temporal arteritis, temporal arteries, liver, spleen, skin and mucous membranes. So after that, you have to investigate him, stop antibiotic and glucocorticoid treatment. So tuberculin skin test or IGRA, false negative in BCG patients, and also false positive in person with he was on any NTM, non-mycobacterium tuberculosis. And for miliary tuberculosis, ideally we have to do the biopsy and fundoscopy in case of retinal arteritis. So what is fluorodeoxyglucose PET CT? That is an 18-fluorine French FDG PET CT has become an established imaging procedure in FUO. So mechanism is FDG accumulates in tissues with high glycolysis rate. So and also it is high advantages are because of our higher resolution, greater sensitivity, higher accuracy. So and also the normal physiological uptake is seen in brain, heart, bowel, and kidneys, bladder. So in periodic fevers like periodic syndromes, so correct timing of PET CT increases its diagnostic value. So we should not do in each and every patient that we have to subject him for PET CT. First, you have to take the proper history, physical examination, relevant investigations. Glucocorticoid must be stopped or postponed. So next is the conventional scintigraphy. This also we rarely do. 67 gallium citrate scintigraphy, and 99 technetium labeled leukocyte scintigraphy. So this is a normal left side. We see the normal FDG PET CT uptake, which is seen in brain gray matter, palatine tonsil, lingual tonsil, liver, spleen, myocardium, stomach, spleen, bone marrow. So in the right side, it is used in the large vessel vasculitis because of increased leukocytosis. So what are the later stage diagnostic tests? So lymph node biopsy and skin biopsy in any skin lesion. Lymph node biopsy like in extra tubercular manifestation or extra pulmonary tuberculosis. So skin screening chest and abdominal CT also is an important later stage diagnostic test. Next is temporal artery biopsy in elderly who has high ESR, ferritin levels, unresolved fevers. So it is also useful. Next is roll of liver biopsy in case of miliary tuberculosis. So next is always repetition of history, physical and examination we should not forget, and do the necessary investigations, and so that we can evaluate the fever of unknown origin. The treatment wise, empirical therapeutic trials are of antibiotics and anti-tubercular therapy. So these are only required in sick patients and seriously deteriorated patients only. First, we have to do proper cultures and we have to give the appropriate antibiotic therapy, right drug, right duration, right route. Next is because of the using prior antibiotics and anti-tubercular drugs that will yield the culture positivity, and also the when the antibiotics are considered is when the patient is not hemodynamically stable or neutropenic fevers. So in those patients we can consider the empirical therapy. So ATT trial also can be considered in granulomatous disease if it is present, or IGRA is positive, not in case of sarcoidosis. So no response for 6 weeks after ATT, definitely it is of no use. We should withdraw the drug. Next, in case of other fevers, colchicine, NSAIDs, and glucocorticoids, like colchicine in familiar Mediterranean fever, these these type of fever are not seen in our country. So glucocorticoid steroids in giant cell arthritis and polymyalgia rheumatica. So in these conditions we have to use the steroids. Sometimes so steroids mask the infection. So masking of infections with continued spread. So always while steroids, always you have to do the sugars, chest X-ray, and you should see look for occult infection before starting steroids. So next is interleukin 1 inhibitor, that is anakinra. It's a recombinant IL-1 receptor antagonist. Like it is used in familial Mediterranean fever, adult onset Still's disease, periodic syndromes. So next is prognosis. Fever of unknown origin related mortality have come down drastically because of the continuous recent advances in the molecular diagnostics, and also with the radio diagnosis also. So majority of fevers are caused by treatable diseases. So don't look like each and every fever. You should not think of fever of unknown origin, and you should not do unnecessary investigations. You should not burden patient with heavy bills. Thank you, one and all, for giving me this opportunity.
Next topic, prevention and treatment of swine flu by Dr. Swati Reddy. Swati just mentioned how to prevent and treatment, because it's a very common problem. Definitely you see that everybody is going to learn some points from this lecture. Okay.
Yeah, good evening. I hope you are, are tired. Let us make my presentation very simple. So coming to the, my topic is prevention and treatment of swine flu. Basically, nowadays we are seeing so many viral infections. So we have to know what is the preventive measures that we have to take so that the transmission of the virus does not spread to the other person. It's our responsibility as well as it's our as a doctor it's our responsibility as well as we have to manage the things so that the transmission should stop. Okay, so coming to the introduction part, it is also known as pig flu because it is a respiratory infection mainly caused in pigs, and it is caused by the virus called influenza A, which belongs to the orthomyxovirus. So coming to the pandemics of swine flu, it is seen in 1918 and 1968. So if you see the pandemic timeline, in 1918 to 1919, the Spanish flu was there. The strain was H1N1. And 1957 to 1958, it was the Asian flu. The strain was H2N2. And in 1968 to 69, the strain was H3N2. And in 2009, the swine flu, that H1N1 strain. So basically, in 2009, the WHO declared the pandemic on June 11 in 2009. So coming to the structure, basically the virus, it contains two proteins, that is hemagglutinin and neuraminidase. Because of this only, there will be chances of novel strains because of the antigenic shift. So if you take the antigenic shift, see if you take the swine flu virus, there will be the RNA particles from the swine flu as well as the human flu or the bird flu. So both these segments will infect the pig cells. And finally, there will be a replication of the virus. So further, it will be transmitting to the other persons while the pig or the person will inhale or like when they cough or sneeze. So coming to the antigenic drift, here only the segment of the RNA cell will be there, but not the complete, the other segments will be not involved. Only the part of the RNA will be involved. So it's a, see, basically this disease is not a direct transmission. It is from the pigs where the avian, the human, the swine flu virus, these are the three viruses which will go into the pigs. So they'll be mixing of the RNA segments, RNA viral strains in the pig. So further, there'll be transmission from the pig cells when the person inhale or when the person cough. So is currently the swine flu virus contagious? Definitely, because see, WHO has standardized into 6 phases of pandemic. So it has entered into the 4th phase, that is human to human transmission. So the incubation period is 1 to 4 days, and the period of communicability means initially when the person is exposed to the patient who is having swine flu, so there will be the features like initially the fever presentation within first day, and the virus will shed off within 5 to 6 days. For even children, it will take more than 10 days also. So coming to the risk factors, the age less than 2 years and adults more than 65 years, and weakened immune system. So the patient who is on long-term cancer treatment and long-term usage of steroids organ transplant, blood cancers, HIV or AIDS, anti-rejection medications, and race, American Indians or the native people, Alaskan native people. So chronic illness like any kidney diseases or CNS manifestations, diabetes, hypertension, asthma, COPD, and the aspirin use under the age of 19 because they are more prone to get Reye syndrome. And pregnancy, so especially they are more in, we can see especially in second and third trimester, and even the risk continues up to 2 weeks, even after the baby is born. And obesity, BAF more than 40, there are the chances of getting flu complications. So as I said, it spreads either from the, while the patient is coughing or while the pig is sneezing or something. So it is spread between the pig and the people. So if it touches the infected pig or if it touches the contaminated part of the particular person or the pig or the pig or the person sneezes or cough, there are the chances of spreading. So what are the symptoms? So fever, lethargy, running nose, sore throat, pain, and lack of appetite, cough, nausea, vomiting, diarrhea. So what are the emergency warning signs of flu? So the child will present in fever, coughing, chest pain, seizures, fast breathing, bluish discoloration of lips, and dehydration and severe muscle ache. So coming to the emergency warning signs in adults, shortness of breath, fever, cough, and pressure in the chest or abdomen, confusion, muscle pain, and seizures, and not urinating. So coming to the investigation, generally we will do the routine investigation to see any the other secondary bacterial infection or is there or not, and LFTs, and basically we will do a chest X-ray to rule out any involvement of the lung is there or not. So other test, diagnostic test is rapid antigen test and direct and indirect immunofluorescent test, viral isolation tissue culture, and nucleic acid amplification test. So basically in rapid influenza diagnostic test, here this test, the sensitivity is almost 10 to 70%, but we cannot distinguish with the other influenza viruses. But it is the most common modality we will be using in our routine clinic setup. And direct and indirect immunofluorescence assays, it is also antigen detection method, and basically the processing time is 2 to 4 hours, and it can also does not distinguish between influenza with the other viruses. And the processing time is 2 to 4 hours, and the sensitivity is 47 to 93%. So viral isolation in tissue cell culture, so the processing time is 2 to 10 days, so the availability is very limited. But it can distinguish between the other viruses, with other influenza A viruses. And nucleic acid amplification test, this test is also very limited, but the sensitivity is 86 to 100%, and the processing time is 48 to 96 hours. It can also distinguish with the other viruses. So coming to the treatment part, proper bed rest should be there, and drink adequate amount of fluids, take proper food, nutritious food, and take the supportive medications. If the patient is having fever, take the paracetamol and the cough suppressants. So generally the treatment is oseltamivir, so which will be routinely used in our practice, and zanamivir. It is basically it's a inhaler form of the medicine which will be giving for the adults or especially for the children. And baloxavir, and it is a new drug which is still in clinical trials, in phase 3 clinical trials. And peramavir, it is also the drug which is given in the IV form, but this drug is also in the clinical trials, like phase 3 trial. So coming to the treatment part in adults, so the treatment is for 5 days. The dosage is 75 milligrams BD dose, and the chemoprophylaxis, like we'll take for 10 days, the dose is 75 milligrams. So even for children, if they are more than 12 months, so depending upon the body weight, the treatment depends. So if the patient, if the child is less than 15 kgs, the treatment is 30 milligrams twice daily, and the chemoprophylaxis is 30 milligrams once daily. And if the patient weight is more than 15 to 23 kgs, the dose is 45 milligrams twice daily, and the chemo prophylaxis once daily. If the weight is more than 23 to 40 kgs, the treatment is 60 milligrams twice daily and chemo prophylaxis 60 milligrams once daily. So if the body weight is like more than 40, generally the what medication we will give for the adult dose, we will give the same medication. And even if the child is 3 months to less than 12 months, the dose is 3 milligrams per kg per dose. It's twice daily dose for 5 days. Whereas chemo prophylaxis, it is for 10 days. The dose is the same dosage. So Janamavi, it is like I told, it is a inhaler form of the device. So the treatment, this is also for 5 days, 10 milligrams, 2 inhalations BD, and the chemo prophylaxis, this is also for 10 days. So 10 milligrams, 2 inhalations, once daily dose. So coming to the side effects of these drugs, so the majority of the side effects are due to the GI complications like nausea, vomiting, dizziness, gastric pain, and the diarrhea. And whereas nevafamir is a drug, the most common is like respiratory symptom because it is an inhaler form of the device. So we have more of a majority of respiratory side effects than the headache, GI side effects. So does every patient should be treated in the OP basis or whether the patient should be hospitalized or not, based upon the categorization we have to do. So if we take the category A, so there will be mild respiratory symptoms like mild fever, mild cough or sore throat without any body ache, headache, diarrhea and vomiting, then there is no need of testing. He does not require the drug also, just we have to tell him symptomatic treatment and just he should be in home quarantine. And if we take the category B1, previously what are the symptoms? Are they like fever, cough, along with the sore throat with high grade fevers, then also no need of testing. He may require home isolation and the antiviral drug. When we come to the category 2, so if the patient is having any risk factors and the patient is having high grade fever or sore throat or muscle pain, so then also no need of testing, but he requires the same treatment. So when he comes to the category C, the patient is having persistent treatment in spite of the taking medications also, or the patient is having repeated breathlessness and convulsions or difficulty in breathing and his oxygen levels are going down. So then there is a need for testing, but that does not make a big difference because when we have to start the treatment and definitely hospitalization is needed for the patient. So coming to the flu vaccines, so totally there are 3 types of vaccines: inactivated influenza vaccine, live attenuated influenza vaccine, recombinant vaccine. So the recommendations depends upon the patient's age. So coming to the flu vaccines, that is 2023 to 24 season. So if we take the age group of 6 months to less than 2 years, we can give the cell-based quadrivalent influenza vaccine, or we can give the quadrivalent influenza vaccine or subunit vaccine. If you take the age group of 2 years to less than 18 years, we can give the live attenuated vaccine. If the patient is allergic to that live attenuated vaccine, or if he has any contraindication, then you can go with the quadrivalent influenza vaccine or the subunit vaccine. So if the patient is having 18 years, age group is like 18 years to less than 65 years, so then we can give the cell-based quadrivalent vaccine or the this recombinant vaccine, or we can give the subunit vaccine. And if we take the age group of 65 years, we can give the adjuvanted quadrivalent vaccine. So that is the high dose vaccine. So who should get a shot? So does every person should get a shot? Definitely, according to CDC guidelines, every patient should get the flu shot every year. So pregnant women, people who live with or care for the children younger than 6 months of age, children and young people between the ages of 6 months to 24 years, healthcare providers and emergency medical service providers, 25 and 65 years of age who have chronic medical disorders or compromised immune systems. Then who should not be given the flu shots? So who is having allergy to the skin eggs, and who has severe reaction to the influenza in the past, and patient who developed GB syndrome within 6 weeks of getting influenza shot previously, and children less than 6 months of age, and people who have fever along with the moderate or severe illness should wait for the vaccine. So coming to the side effects, so this flu shot, what are the side effects? That basically the patient will be complaining of redness, swelling, fever, aches. And what about the flu mist, like live attenuated vaccine side effects? Generally, running nose, wheezing, muscle ache, headache, fever, sore throat, cough. So coming to the guidelines of infection control. So pre-hospital care and the hospital care. Definitely, everybody should wear a three-layered mask, not the ordinary mask which we routinely use. And definitely, we have to use PPE kits, and there should be a proper sanitization room. Even if the ambulance is also is infected, then also the ambulance should be sanitized. And during the hospital, so if the 7 days after the resolution of the symptoms for the adult, there should be disinfection control. For 10 days of the resolution of symptoms for children, there should be again disinfection should be used, and sample collection and handling is also very important. So infection control level at the individual level. So avoid close contacts. Maintain distance at least 6 meters. So when you are sick, so please avoid overcrowding when you are feeling very sick, because it will it will spread to the others, and there is a chances of getting infection, that the transmission of disease will be growing on. And stay home from work or school when you are sick. It will prevent others from getting infected. So cover your mouth and nose with mask or tissue. So many people will be wearing mask, but this is not the technique which I have shown in the slide. We have to wear completely so that it covers both the nose and the mouth. So hand hygiene, definitely hand hygiene is also very important, because if you maintain a hand hygiene also, definitely it will prevent the spread of the flu. So I know everybody know how to wash your hands properly. And coughing manners. Sometimes the people will be, even the doctors, I have seen so many doctors coughing in front of their faces, but that's not the correct way. So wear the proper mask, or if you don't have a mask, put a tissue paper or a handkerchief so that it will prevent the transmission of the disease. Or if you cough or sneeze, just into your sleeve. That is the way to cough. So avoid touching with hands, avoid contact with the eyes, mouth, and the nose. So this is overall the slide, how to prevent yourself and the others. Just cover your nose and the mouth with a disposable tissue. When coughing or sneezing, disposable of used tissues in the proper sanitation area. If you have flu-like symptoms, just seek the doctor immediately. Just maintain a distance of 1 meter from the other people. Just regularly wash your hands properly. And if you are just stay back and take plenty of fluids, and avoid hugging, kissing, and whatever, shaking hands. I think this is the culture what we follow. That is the best way. And avoid touching eyes, mouth, and mouth instead of without washing your hands. So what are the complications that we can see? So worsening of the conditions like asthma and heart diseases. Patient may land up in ARDS, finally leading to respiratory failure. Secondary bacterial infections, pneumonia, and neurological symptoms like confusion to seizures. So get a flu vaccine to protect yourself, your family, and your community. Just fight flu. Thank you. Spread the word, not the germ. Thank you.
Oh, it's okay. Thank you, Dr. Swati, for excellent overview of prevention and treatment of swine flu. Before I go to the next topic, let me extend my warm welcome to Senior Director Dr. Krishna Rao Garu from Maheshwaram Medical College, and Director Dr. Sabita Sukhdev from Rajarajeshwari Medical College. So hearty welcome, sir. We will continue the CME. We have two topics. The next topic is how to prevent cancer for medical practitioners, followed by lipid management. In the lipid manage, I'm going to, because the time is running short, so I will interact with all of you, myself and Dr. Patsar, both of us. He will show some slides. I will ask you some questions so that it will be interesting to you. So we will highlight mainly the prevention of the hyperlipidemia, how to manage it. So Ravi, yes, over to you. You can come. Yeah, go. Just check. मिनट उधर आ रहा है क्या? नहीं दिख रहा. Duplication. Duplicate. Yeah, yeah. Only basics. Advanced. Yeah. Yeah, sir. Just now, sir gave me a disclaimer that cancer is a Greek and Latin word for the MBBS residents. So I never studied anything related to cancer during my MBBS period. So, but my presentation intent was, because you are an MBBS resident, a lot of questions might be coming to you saying that, hey, you are a doctor, I have this problem, so what should I do? Or you might have some relatives who would be troubling with some malignancy or cancer related problems. So as a MBBS resident, what you should suggest to those people? First, coming to the cancer incidence and mortality, these are the number of cancers as per 2020 Globocon data. The most common in the world are breast, lung, and colorectal. Whereas in case of the India, according to 2020 data, the 4 cancers are breast, oral cavity, cervix, and lung. These are the most common cancers in India. So next, coming to the cancer risk, who is at risk? What is the current trend, and can it be reduced? Yes, definitely everybody is at risk of cancer. Don't think like I don't have any family history, I will follow the strict lifestyle, so I will not be at risk. That is a wrong notion. Everybody is at risk of cancer, and the risk is increasing significantly over the years. And yes, by taking some precautions, we can reduce the cancer by almost significantly by 30 to 50%. The next, coming to the cancer etiology, there are various risk factors for the cancer. Whether these risk factors are modifiable or not, are we sure that this risk factor can cause cancer? And if it causes cancer, how big is the risk for the individual with that specific risk factor? For example, let's see only 10 to 15% of the patients or cancer patients are inherited, that is they run through the families, but rest of the 90% of the patients will not have any family history. Either they have bad luck because of the random errors in the DNA replication, or because of the behavioral factors like lifestyle, environmental, occupation, hormonal, all these factors can also contribute to the development of cancer. So these are the modifiable, non-modifiable, and partially modifiable risk factors. The unmodifiable one are errors in the DNA replication, whereas the modifiable one are exposure to radiation, chemicals, infection, lifestyle changes such as smoking, lack of exercise, and nutrients. So if you look at the strength of evidence for these risk factor, you can see the group 1 which are carcinogenic to the humans. There are 126 such agents which are carcinogenic to the humans, which includes tobacco, alcohol, radiation, and all those things. And similarly, there are group 3 which is not classifiable as a carcinogen to the human. There are 500 such agents are there. Luckily, coffee is not a carcinogenic. We can have your coffee. And next, coming to the strength of association. So for each malignancy, there are multiple risk factors. I just wanted to highlight especially for the breast malignancy because it is the most common. Early menarche, that is less than 10 years attaining periods. Late menopause, not having children, nulliparous, not giving any breastfeed. So obesity, all these are the risk factors for developing breast cancer. That doesn't mean like everyone who attained menarche by the age of 10 years will develop cancer. Or similarly, that doesn't mean if a patient does not attain menopause by the age of 50 will develop cancer. There is a risk for that.
if you look at the risk factor relative risk, the weak risk relative risk is 1.1 to 1.9. For example, menarche, menopause, obesity, all these are weak relative risk. That means when compared to the normal individual, they will have 20 or 30% extra risk would be there. If a patient has radiation which has been received for the Hodgkin's lymphoma previously, then the risk would be very high. If a patient has a personal history of some ductal carcinoma, pre-malignant lesions, then the risk would be very, very strong. So you should not worry for each and every risk factor. You should be looking at what is the strength of association for the risk factor, and then you have to act accordingly. So next, the important point. So how we can prevent the cancer? What are the modes of prevention? As everyone know, there are primary prevention, secondary prevention, and tertiary prevention. Primary prevention is basically measures taken to lower the risk of developing cancer. That is, these are the measures which would be taken in an asymptomatic individual. Secondary prevention includes two modalities. One is screening techniques, and the second one is early detection without delaying. So if you look at the primary prevention, we have to focus mainly on our behavior, like tobacco usage, alcohol consumption, diet, weight, physical activity, infection, and other changes. We will see one by one. Tobacco can causes more preventable cancer deaths than any other risk factor, what I am going to mention in the coming slides. So it is a deadly combination. So never ever go to, because you are young residents. So everyone would be prone to have these kind of tobaccos or non-nicotine products or like cigarettes, e-cigarettes. See, whatever the branding the company people will do, cigarette is a cigarette. So whether it is a smokeless tobacco or smoked tobacco, the risk would be the same. So don't fall for that tobacco. And coming to the alcohol, so someone will say like taking small bits of alcohol is good for art. I'm not sure. I think Dr. Kasturi sir needs to clarify on that. But from the oncological point of view, no amount of alcohol is safe for cancer. I can quote you some 12 cancers which can come if you take alcohol. So be very cautious. Never ever go to the alcohol zone. So next, coming to the physical activity. So everyone will say like the more time you spend in the physical activity, the better it is in terms of for each and everything. It will pertains to the cancer also, because breast cancer, colon, endometrial cancers, most of them occurs because of the lack of physical activity. So the underlying mechanism is because of the inactivity, the obesity will occur, and because of the obesity, there are some insulin and related hormonal changes which will attribute to the development of cancer. Next, diet. So this is the most common now. What all diets are there? If you open the Google or if you open the YouTube, Veeramachineni diet, keto diet, what diet, that diet. My only thing from oncological perspective was, if the patient is taking, if you are taking any high processed meats, okay, like charcoal, tandoori chicken, red meats, all those things, they will have an increased risk for the colorectal cancer. Your diet should have rich in the vegetables, fruits, and whole grains. Limit the high calorie fruits, processed foods, especially the fat, sugar, or starch. Avoid sugary drinks. Avoid processed meats. Limit the red meat and foods high in the salt. See, all these are, I'm not just saying by without having any evidence. Each and everything has a clear-cut evidence saying that if you don't follow all these things, there is a significant risk for developing malignancies. And coming to the obesity, as I mentioned previously, it is a risk factor for the breast cancer, colorectal, and endometrial cancer. So the recommendations are keep your weight towards the lower end of the healthy adult BMI range. So that is 18.5 to 24.9. My BMI is 21. So the waist circumference should be below 80 centimeter, and hip to waist ratio should be less than 0.85. So coming to the next infections. So the most common infections are H. pylori, HPV, and then hepatitis B and hepatitis C viruses. So if you have this infection, then they are prone to have these malignancies. Then the most, I think, like everyone now would be knowing that we can prevent the cervical cancer by taking HPV vaccination. Is it true or what? The recommendations, WHO recommendation was like every girl from 9 years of age can take HPV vaccination. From 9 to up to 14 or 20 years of age, even one shot is sufficient. More than 21 years, up to 26 years, 2 doses with a gap of 6 months is more than sufficient. If the patient is immunocompromised, better to take 3 doses. So I think most of you would be in this range only, 9 to 25 years range. So I would recommend to take 1 shot of HPV vaccination. But before taking vaccination or after taking vaccination, these things should run in your mind. Whether is it really going to decline the cancer cervix incidence? There is no evidence that the HPV vaccine will prevent the development of cervical cancer. The evidence is only that the precancerous lesion will be decreased by taking the HPV vaccination. By doing so, the eventual cervical carcinoma will be decreased if you decrease this precancerous lesion. And the protection is not lifelong. It is only for 10 to 12 years. And if you look at the cost-effective analysis, one, for example, let's say who has taken HPV vaccination, and on the other hand, someone has done the cervical cancer screening, I would say cervical cancer screening is more cost-effective analysis in the mass. As a nation, cost-effective analysis is cervical cancer screening. But if you look at individually, HPV vaccination, taking HPV vaccination is also better. So consider taking at least 1 shot or 2 shots between the age of 9 to 26 years to prevent this cervical cancer. Next, ultraviolet radiation. Lot of you might be seeing like tanning is a new fashion nowadays. Okay, so it can also cause various malignancies, especially skin-related malignancies. Better to have some sun-smart behavior, better to have some protection at the work and prevent tanning devices. And there should be a legislation which would come to suppress these tanning devices. And again, environmental. Outdoor pollution, indoor pollution, exposure to the radon which is located in the soil, and arsenic, all these are contributing factors for the development of the malignancies. Expositional hazard, especially working in the radiation centers, imaging, asbestos, painting or dryers, and then cutting shops like especially the hair dryers, continuous exposure to the dye, all this also can lead to the some amount of risk of malignancy. So these are the primary prevention, like mainly concentrate on your behavioral changes, no tobacco, avoid alcohol, no amount of alcohol is safe, and then maintain some strict, do not fall into the obesity range, maintain some physical activity, and then occupational hazard, better to have some restrictions, and avoid the sun tanning and all those things. In food also, avoid the red meat or processed meat. And coming to the secondary prevention, I think this is bit ahead of you. I don't think you will understand, but at least concentrate on 3 or 4 malignancies, especially the most common one. Screening is nothing but you need to understand this. The screening is a technique which needs to be done on a healthy and asymptomatic individual. For a healthy and asymptomatic individual, if you are doing some investigation, that is called as screening. And the prerequisites before doing any test would be the prevalence of the disease should be high, early detection should lead to better outcomes, and it should be acceptable and affordable, and effectiveness should have been demonstrated previously before undertaking. There are a lot of benefits. Everyone will quote you benefits. On the other side, I will quote you the harms. The consequences of false positive, that is additional intervention, psychological harms. The consequences of false negative, that is false sense of security. Coming to the most common one, that is the breast malignancy. For example, let's say all of you are like might have some relatives, some 40 years to 50-year-old female lady sitting in your home. If they come to you and ask you, hey, Dr. Ravi, can I go and take that screening mammography as a screening technique to prevent the breast cancer? My answer would be straight away no. Okay. So if someone asks you, can I go undergo screening mammography? I think bluntly say no. But then where are all these recommendations and all these things coming are? Mostly the data is from the US or UK. And we are extrapolating the data from US and UK, and we are implementing the same in our Indian context, which does not hold true for each and everything, because all these results are based on the non-critical acceptance of the studies. Harms received the little attention because of these screening techniques. Overdiagnosis was completely underestimated, and there is poor understanding of the natural history or biology. So in Indian setting, rather than screening mammography, I would recommend clinical breast examination. Whenever you want to have some, if you have some doubt, go to the doctor or like a gynecologist, medical oncologist or surgical oncologist, do the clinical breast examination. That will solve the problem for 90% of the patient. I'm not just quoting it. There is a clinical, multiple studies has been conducted. My parent institute, Tata Memorial Center in Mumbai, has conducted the same. And they have quoted that why we are favoring clinical breast examination rather than mammography was, the goal of screening is to prevent the death and not to simply detect the cancer by mammography. Mammography does not detect some cancers early, but many of these are not potentially lethal, and their detection causes needless anxiety. Whereas clinical breast examination is more likely to detect the cancers that are potentially lethal. So clinical breast examination is the most important one, even in the screening methods rather than mammography. So next, coming to the cervix, this is the second most common. Pap smear, visual inspection with acetic acid, and HPV testing. These are the three screening methods. So several studies has conducted and they have quoted that either visual inspection with acetic acid or HPV testing. So both these are necessary or sufficient to say that you don't have any, the chances of you developing cervical cancer would be significantly less if these tests turns out to be negative. So once in your lifetime, between the age of 30 to 49 years, twice in a lifetime screening would be more than sufficient for the cervical cancer. Either you can choose visual inspection with acetic acid or you can choose the HPV testing. Once it comes out as negative, wait for 5 years and do the second test. So if both are negative, then forget about cervical cancer in your life. And then the most common and important one are the oral malignancy. On the left side, you can see that leukoplakia, on the right side, that is erythroplakia. So this is the another common day-to-day consultations I will see in my OPD. Patients will present with this and everyone will go jump and go and do the biopsy for that patient. That is not the guidelines. Whenever you encounter any pre-malignant conditions such as erythroplakia and leukoplakia, first avoid the, do the tobacco cessation or alcohol de-addiction center. First, remove the agent which is causing that leukoplakia or erythroplakia. Wait for minimum of 4 to 6 weeks. If still the lesion persists, then go ahead and do the biopsy. So oral cavity examination is the important screening method to prevent the head and neck malignancies. Colorectal cancers, again, it is on rise in Indian setting, especially in the young population. So you might be hearing like everyone is going to do like colonoscopy, sigmoidoscopy. So all these tests, my understanding was, as an individual basis, it might hold true that doing colonoscopy and sigmoidoscopy. But as a nationwide, it is not viable. And you don't have to do the scopies for each and every patient. Some fecal based tests are there. If some symptoms are there, then only go for these scopies. Otherwise, just do the clinical examination and be follow up with your consultant. That would be more than sufficient. So in conclusion, the risk of cancer is high. Everybody is at risk. Don't think like if you don't have any cancer family history, if you are following strict lifestyle, then also you can develop any of the cancers, and the risk can be reduced significantly by 30 to 50%. Only 5 to 10% of the cancers are inherited. Tobacco causes more preventable cancer than any other. No level of alcohol is safe for our health. Sir, I want your comment on with regards to the cardiac status in terms of alcohol. But for my side, no alcohol is safe for oncological perspective. The more time you spend in the physical activity, the better it is. Maintain BMI in the range of like 18.5 to 24. So in Indian setting, for breast malignancy, if any of your relative ask for the screening mammography, bluntly say no and do the clinical breast examination. And for cervical cancer, if any of you want to get the HPV vaccination, the timing is 9 to 26 years. You can get 1 shot or 2 shot. That would be more than sufficient. Even if you don't get that, at least once in your lifetime, do the cervical screening. That would be more than sufficient. And it is no screening techniques are available for endometrium and ovary. And oral cavity examination is important for oral cancer. And lastly, colorectal cancer screening is not viable at community level. It can be done at individual level after proper discussion. And thank you. Thank you, sir, for giving me this opportunity.
Alcohol, sometimes people say it's a good to prevent the cardiovascular disease.
Yes, sir.
But that is not true. Actually, when you binge, it can lead to cardiomyopathy, alcoholic cardiomyopathy, known entity. And if they binge, it may lead to atrial fibrillation, irregular heart rate leading to stroke and everything. So Western countries, because of their weather, they recommend 1 or 2 pegs. If you exceed more than 2 pegs, but everybody is prone for ups and downs in the life. So if somebody's, all are not very, sometimes some people are very sensitive. In particular point of that time, he may tend to take more. He may go into binge, and that may. I've seen some patients coming with severe refractory cardiac failure. One of my patients, he lost his son. He locked his door and he went on taking massive amounts, and almost 10 days later came with a massive pedal edema and congestive cardiac failure. Then we forced them to, most of the time they will have B1 deficiency also. You have to give the B1 and alcohol a known entity. And it has many other effects like a burning feet syndrome, neuropathy effect, encephalopathy, so many, and fatty liver. In the long stage, it lead to hepatocellular carcinoma. So avoid. There are two pleasures in the life. One is simple pleasures. That is, be positive, be good to everyone, and always academic, skillful. And this is achieving the knowledge. These are all simple pleasures. Foolish pleasures. Foolish pleasures always lead to stress. So many youngsters are there. Please don't indulge in any foolish pleasures. That may give a temporary happiness, but long lasting stress. So don't indulge, don't get tempted to in that direction. So temptations are there in the life, but don't get tempted because every temptation will lead to some kind of stress. So the integrity of the person is important, particularly so in a doctor's profession. Doctor's profession means you have to stand for values, principles, ethics, and empathy toward the patient. These are very, very important. And always you should be skillful, you should be knowledgeable, you should be responsible, you should be supportive of the patient. So these are possible only if you imbibe all those, always be friendly with everyone, maintain the positive relation, that will go in a long way. Nothing like a good relation. Good relation carries immense value in life. So that will go in a long way. Alcohol, I am completely dead against. Don't indulge. So youngsters are there. Suppose if you are starting at the age of 25 years, you have to go a long way. Nowadays, lifespan gone up to 80, 85. Actually, now the 72, 73 years. But in another decade, definitely it will prolong. We are exposed to more and more toxic substances. What benefit you are going to get in the lifestyle, these things will emphasize so that you can practice in your life. This is useful to everyone, like I'm managing that. Everybody is prone as the age advances, prone for hypertension. Nobody is immune. Hypertension, diabetes, and cholesterol. Once you cross the 40, sometimes it can happen if the lifestyle not maintained. It can they can manifest at an early age also. So always maintain good lifestyle. That makes a lot of difference. Go ahead. As per the 2021 statistics across the world, the global death rate, if you see, almost 21 million people died. Average statistics. Among 21 million deaths, cardiovascular diseases contributed to 32% of deaths. If you see the premature deaths, like between age group of
vascular disease. And also in India, it is more prone for ASCVD compared to the northern states, and also it is more prevalent in urban areas compared to the rural areas. And this is a simple calculator that is available online. It is an ASCVD risk calculator. It will give the 10-year risk of developing first cardiovascular event or cerebrovascular event in the next 10 years. So the commonest variables that have been involved in the computation of this risk calculator is age, race, sex, and also the diabetes, and also smoker, and also hypertension, and also if it is being controlled by the blood pressure medication or not. We have to be included in the calculation of this risk. So it is an exhaustive slide. Here you can see that it is based on the score, that is less than 5% it is low risk and more than 20% is high risk. So if the patient comes under 7.5 to 20% and more than 20%, it is calculated as high risk, and you have to treat them aggressively by statins or other anti-hypolipidemic drugs. If it is comes under less than 5% and also in the range of 5 to 7.5%, the first strategy should be a lifestyle management followed by the medication based on the patient profile. And in order to simplify the previous slide, we have got the Indian guidelines. Here, if the patient is having risk factors like diabetes or a target organ damage because of the diabetes or hypertension, and also if there is any evidence of CAD or CVA, the patient should be treated aggressively. If the patient is having no organ damage with risk factors of diabetes or hypertension, you just have to first try for a non-pharmacological treatment like lifestyle management, followed by the medications like the statins. And coming to the lipid management, it is of two types. One is the non-pharmacological treatment. Another one is the pharmacological treatment. The first lifestyle management is very important in every aspect of the diseases like the cancer or CAD or CVA or whatever it may be, or hypertension or diabetes. So as previously mentioned, we have to walk for at least 150 minutes per week, and that should be at least around 30 minutes per day. And you can walk for at least 5 days per week. And also you can go for a resistant training like aerobic exercise. And also you have to go for if the patient is taking statins, they can complain of myopathies and also myositis, and they will be telling that if it is fatiguability and also myopathy. So in these patients, we have to first reduce the dosage of the statins so that they can have the reduced symptoms, and also they can go for a gradual increase in the duration of the workout. And also there is a concept called atherogenic dyslipidemia. It is very quite common in Indians, where there will be increased small dense lipoproteins and also increased triglycerides with a decreased HDL. So we have to target that atherogenic dyslipidemia because it is a causative factor for majority of the pathogenesis of the atherosclerotic vascular disease. So dietary regimen. So you will be more interested in taking this cakes and pastries. So, but however, taking these foods for a prolonged period of time will lead to increased triglycerides and also decreases the HDL, and also it will also increase the LDL cholesterol. So it can lead to various amounts, various complications like the dyslipidemia that can in turn lead to CVA or CAD, or also it can lead to CKD also. So our dietary regimen should consist of a Mediterranean diet, and also it should be contain saturated fat should be less than 6%, and also it should be including more of the monounsaturated fatty acids, and also complex carbohydrates also should be cut down. And also you have to, there is a saying that the using of non-pharmacological supplements like nutraceuticals, they have a benefit in the development controlling the LDL, but however there is no role and also there is no evidence for the treatment of this dyslipidemia by the nutraceuticals. And you have to cut down your sodium intake, that is particularly in patients with hypertension and also patients with heart failure. And also coming to drug therapy, I don't want to go into much of the drug therapy, and because however the statin is the one and most important drug, that is first line drug treatment for the treatment of the dyslipidemia. So what is a statin? It is a HMG-CoA reductase inhibitor that is involved in the synthesis of the cholesterol. That cholesterol is vital for the synthesis of various hormones and also various lipids hormones. So that's why statin will target this HMG-CoA reductase, and it can lead to a reduction in the LDL cholesterol by 50%. And it is used in the management of primary prevention and also secondary prevention. And also South Asians, they are high hyper responders to the statins, and we Indians are having increased response to the statin. But however, this hyper responsiveness is also seen with the side effects like myopathy, and also patients usually come to our OPD with the myopathy and also fatigue, and also sometimes we have seen cases of rhabdomyolysis also in patients who are initiated on statin therapy. So, what is high intensity statin therapy? So, rosuvastatin 20 to 40 mg and atorvastatin 42 mg is the high intensity statin therapy. And what are the adverse effects of statins? As mentioned previously, one is the myopathy and another is the hepatitis. So this is quite common in patients. But however, and also there is a myth that statins will cause diabetes. So, but however, there is in patients who are pre-diabetics, anyway, over a period of time, they will go into range of diabetes. However, when we start the statins in these patients, there will be increased incidence of diabetes diagnosis in this patient. So that's why, but however, the benefit outweighs the risk, and also this is confirmed in Jupiter trial also. And there is, we have to monitor the regularly the liver enzymes and also muscle enzymes like creatine phosphokinase in patients who are taking statins. So I don't want to go in much of this statin-associated myopathy. So if the patient is having rhabdomyolysis, we have to stop the statin and we should not reintroduce the statin to that patients. And if the patient develops myositis, you have to wait for at least 4 weeks. If there is any declining trend in the CPK, then we have to go for slowly increasing the statin, and also we can try an alternative statin like rosuvastatin or atorvastatin which the patient is taking. So these are the various drugs that have been implicated in the management of the diabetes, dyslipidemia. But however, the main emphasis is recently is being going on regarding the PCSK9 inhibitors. Here, when we take a PCSK9 inhibitor, there will be increased availability of the LDL receptor, so that the circulating LDL will be bind to the LDL receptor, so that it will decrease the LDL cholesterol levels. So it is available in India, that is in the under the brand name of Repatha. It has to be taken 140 mg every 2 weeks or 420 mg every once monthly. So it has been shown to reduce the LDL levels by around 50 to 60%. In patients who are intolerant to statins, this is the best drug. But however, cost effectiveness has to be considered when considering for the patient. And recently we have seen in the newspapers and also media that one injection came into the market that will reduce the incidence of the cholesterol, and also it will reduce the events like the CID and also CVA. This is inclisiran. It is available under the brand name of Cybrava in India. It has to be taken 284 mg on the day 1 and also on the day 90, and it has to be repeated every 6 months onwards. And it has been effectively reducing the levels of LDL by about 60% compared to other pharmacological therapy. And it is nothing but a small small interfering RNA that will prevent the transcription of PCSK9, so that the availability of LDL receptors in the hepatocytes will be more, so that it can trap the circulating LDL. So whenever a patient presents with ACS, we have to start the high intensity regimen in these patients like rosuvastatin 40 mg or atorvastatin 80 mg along with the ezetimibe. So we have to reassess the patient after 4 to 8 weeks. If the patient is having still the LDL cholesterol level of more than 55, then we have to go for another alternative therapy like a PCSK9 inhibitor or inclisiran. If the patient is having less than 55, it has to be maintained over the drug for a period of time. And when we can see in patients in our OPD that the patients will be coming to us with a stable atherosclerotic vascular disease. In these patients, we have to be starting the statin in a moderate intensity, that is rosuvastatin 20 mg and atorvastatin 40 mg. And we have to maintain the target level of more than 55, less than 55. And if it is more than 55, then we have to go for other measures which have been indicated previously. So we can see in our normal population, even if you test right now, you will have an increased levels of triglycerides. So what level of triglycerides is dangerous? So if it is more than 500, then we have to start the therapy for reducing the triglyceride levels. Otherwise, it will lead to a complication called pancreatitis. So that's why in patients who are having triglyceride levels more than 150 to 499, based on the risk factor profile, and also if the patient is diabetic, then we have to go for the intensive medical therapy. If the patient is not diabetic and having no risk factors, then you have to advise a lifestyle modification in this type of patients. And if it is less than 150, there is no need for starting any therapy. We have to see the non-HDL cholesterol, which is nothing but the combined triglyceride soluble small dense lipoprotein and other VLDL and IDL. So recently one marker came into the limelight, that is a lipoprotein A. It is a marker which will be determined genetically, and it is being not changed by any of the medications which were in the market right now. So it is a lipoprotein A. So it has to be tested in each and every individual at least once in a lifetime. And another one is the ApoB marker, which will give you the entire level of the entire body level of the LDL protein, and also the lipid content. So it has to be less than 65 in patients with very high risk, and it should be less than 80 in patients with a high risk. Thank you.
Thank you, Partha. Wonderful presentation. Finally, we have come to an end. Before I conclude, I am very thankful to the Maheshwaram Medical College management and students who participated in this program. You are so amazing, so wonderful. Frankly, amazing spirit. You have been consistently sitting there all the time, and that is the spirit you maintain. Untiring spirit, frankly, because exhaustive lectures. You should have guts to listen to that exhaustive lectures. But anyhow, but they have given so many important topics. The person who is paying attention, definitely they can learn a lot of points. They made enough effort to make it useful to you. And with this note, let me request Krishna Rao garu and Savita Sukhdev garu to come out to the dais, and along with Adam, Dr. Adam. Dr. Adam is a superintendent of Maheshwaram Medical College. He is a senior director. Madam is a director for Rajareshwar Medical College. I am very closely associated with this medical college, so very long association. So, sir, I call just to kindly felicitate our speakers with mementos. I will call one by one. You can come. You can come and invite one by one so that they can felicitate. Here it there. You can first name, second. You follow the order.
All right, thank you very much, Dr. Sridhar, to have concluded the event such wonderfully. Now, as you rightly said, let us felicitate and thank our speakers for taking their precious time out and being a part of this wonderful symposium. So without much ado, I'll take this opportunity to first request Dr. Himanshu Bhatia to please step forward. Thank you so much, sir, for your talk on management of hypertension. Ladies and gentlemen, let us thank him with a huge round of applause. I'm sure this symposium was very fruitful for everyone who has witnessed it. Thank you very much, Doctor. Next, I would humbly request Dr. Partha Sarathi to please step forward, who has given the lecture on management of lipids. Thank you so much, sir. Thank you, sir, for being a part of this wonderful symposium. Next, I would humbly request Dr. Rohan P. Reddy to please join us. He is left, so I humbly request Dr. Sirish Kumar to please step forward. Thank you so much, sir. He's given his talk on asthma management beyond inhalers. Thank you so much. I would now request Dr. Pawan Reddy. Dr. Pawan Reddy to please step forward. Let the claps keep rolling. Let us thank them in our own way by giving a huge round of applause. I would also request Dr. Ravi Krishna to please step forward. Has given his talk on how to prevent cancer. Last but of course not the least, I'm really partial towards my gender, so I request you to give them a much more thunderous clap to Dr. Swati Reddy, who has spoken about the prevention and treatment of swine flu. Thank you so much, ma'am. And of course, let us thank our dignitaries to do the honors and being over here a part of this wonderful symposium. Let us have a group picture, sir. Let us have a group picture. Let us capture this moment together. Ladies and gentlemen, this is the end of this wonderful and enlightening symposium, and I'm sure everyone who have witnessed it is taking something along with them in terms of knowledge and exposure. So, one last time with this wonderful set of dignitaries and doctors, let us thank them with a huge round of applause. Sure. All right, ladies and gentlemen, this is the end of the symposium, but I know everyone sitting over here is eagerly waiting for the award ceremony to begin. So I promise you that it's going to be a wonderful award ceremony for which we'll take a breather of 15 minutes and I'll see you on the other side of this small little break, a coffee break, a bio break, whatever you want to call it. Just think in all the knowledge you have just witnessed and heard from all the renowned doctors and take a break for some time. I'll give you a few more minutes before we begin the award ceremony. Thank you. A small announcement to be made, especially for the students who have joined us for the symposium. I humbly request you all can, I think you have taken the knowledge which you wanted. So I request you all, you can go home. I think your parents are waiting for you. You can go and share your experience about the symposium. All right. Thank you so much for being a part of it. Right? Can we have a huge round of applause for yourself for being a part of this wonderful symposium? Yes, thank you so much. Thank you.